Welcome back, everybody. Again, thanks for joining us on our fifth annual Spinal Cord Injury Education Day. We are going to move on to our second set of speakers here, and their topic is women's health in spinal cord injury. Please join me in welcoming Stacy Elliot and Sarah Sims. Stacy Elliot is a sexual medicine physician at GF Strong, and Sarah Sims is a physiatrist in Vancouver. Welcome, ladies. Thanks for joining us and sharing today.
Thank you. Can you hear us okay?
Yes.
Okay, great. So listen, I'm Stacy Elliot. I'm a physician that consults to the Sexual Health Rehab Service. And I've been doing sexual medicine for many years. I don't want to tell you how many. And Sarah?
I'm a physiatrist. I'm a more recent grad here at UBC, and I work at GF Strong. I do work on our spinal cord injury floor as well as a number of other services.
So our objectives today are understanding a little bit about sexual dysfunction. Obviously, we're just going to breeze through the superficial part of it because it's a huge topic. I'd like to show you how to apply the sexual health framework. I want to discuss a little bit about reproductive issues for women with SCI and menopause, Sarah will talk about, and how they overlap with some of the conditions that women with spinal cord injury have. And when we're talking about women with spinal cord injury, we're going to be talking about women that are born with female genitalia. Okay, so first of all, sexuality after SCI. I'm going to speak very briefly about that. Okay. One thing that's very important, this is an older study. I'm sure you've all seen it, Kim Anderson's study, but she looked at all the pelvic organ functions and all the other motor and AD, et cetera. What is the most important thing for people with spinal cord injury? And you can see that in the quadriplegics, hand and arm function was the most important, but look at sexuality came in second. And in paraplegia, it was first. So when we're looking at priorities for tailoring treatment to rehab interventions, or whether or not we're maximizing the quality of life, or we're looking at studies, we have to remember these priorities. And that has not been the case over the last time that I've spent in sexual medicine and SCI. So it's coming to the fore now, which is great. And if we look at sexual dysfunctions in women with spinal cord injury, looking at sexual desire disorders is very biopsychosocial. It's quite complicated. Sometimes we need to have referrals to psychology, psychiatrists, or sexual medicine experts. We have a sexual health rehab service in Vancouver. We're incredibly lucky to have that. So again, we send a lot of referrals there. Then we've got genital arousal disorders. In men, that would be erectile dysfunction, but in women, it's vaginal lubrication and accommodation. And then we have orgasmic disorders, and women with spinal cord injury do have a slightly improved ability to reach orgasm than men do with spinal cord injury. But of course, it depends on the completeness and level of injury. So if you have some genital sensation and some incompleteness, you're more likely to be orgasmic after spinal cord injury. But we have to remember the secondary consequences of spinal cord injury completely interfere with this whole sexual experience. So we're going to look at some of the stages of women's sexual and reproductive health. I do want to say, though, that I think we have to keep in mind around sexuality that it really is a pursuit of pleasure and orgasm, but not necessarily having to have an orgasm. An orgasm is the brain's interpretation of what goes on in the body. So it is a brain phenomenon. You can have it during your sleep, through tantric sex, etc. And we need to remember that because neuroplasticity is very important after spinal cord injury. Yes, the best chance for a female to have orgasm after spinal cord injury is usually some sort of pelvic stimulation, but there are other women that are orgasmic with ear, a nipple, breast, all sorts of other erogenous zones that can build up that arousal and cross that orgasmic threshold. And this release is usually associated with pleasure, but it's very often takes a lot longer, more stimulus than prior to injury. So when we look at sexuality, it's a complex issue. Peel back all these layers of onions, everybody gets lost and intimidated. And really, we've developed a sexual health framework or a table. It's a one-pager that you can use in your charts, and it can be very helpful. The actual, if you look at the top, it says spinal cord injury, the actual paper on it is all about how the different disciplines come together and how they can all help with sexual activity and sexual feelings after spinal cord injury. So looking at an example, this is what our one pager would look like, the sexual areas. We've got drive and interest, we've got sexual function, but look at all the other areas that encompass sexuality and how people feel about themselves after spinal cord injury. And I'll just mention some of them very briefly here. For example, after spinal cord injury or disease, sexual drive often is either the same or reduced depending on life circumstances often. Women often have difficulty with lubrication, depends whether it's psychogenic or reflexogenic, of course, depending on the level of injury and completeness. Fertility is more or less unaffected, but I'll talk about pregnancy and labor and contraception in a minute. The factors around the condition are very important, especially autonomic dysreflexia with high arousal. It can be enough to turn people off and not want to be sexual, especially with orgasm. And of course, medications can affect sexuality. You can have motor and sensory influences where you've got areas of hypersensitivity, which are uncomfortable, or hyposensitivity, sexual positioning, spasm, all these things we consider. Bladder and bowel influences, again, you've got a neurogenic bladder. You can take the catheter out of the way. Some women go for a Maternal surgery in order to get away from all the catheters around their genitalia. It's a very specific management per woman. And then we look at your sexual self-view and self-esteem, and that can be very variable, but it's very important because that's part of who you are as a sexual person, how you present yourself to the world. And again, partnership issues, whether they have a partner or not, can they maintain the partnership, all sorts of things. These are all part of sexuality. It's not just about genital function. A very helpful thing is to look at SCI sexualhealth.ca. This is part of our website that you can go to. And again, it uses sort of the framework to help give all sorts of information for both healthcare professionals and for people with lived experience. And there's videos and everything on there. So I really recommend you scroll through this because it can be extremely helpful for you and your patients. We also did a Pleasure Able manual, which is a sexual device manual. We did this about 10 or 15 years ago. And it's had huge uptake because it was done by occupational therapists. So it's very helpful about what to do. We're now doing a second version, which will be much larger and more inclusive. And that should be out within the year. And you can Google that too on the same site. So fertility for women with spinal cord injury, of course, as you know, immediately after injury, they often have amenorrhea from 4 to 5 months or even longer. But in general, fertility, unlike men who have erection, ejaculation, and semen quality problems, women after spinal cord injury mainly maintain their fertility. So the real issue is around birth control. And that has to do with what you can manage with your hand function, with whether you've got independent self-care potential. If you have a concomitant brain injury, can you remember to take your birth control pills every day? Of course, the estrogen and progesterone risk, low dose pills seem to be fairly used quite often if you have decent mobility, even as a quad. But again, systemic oral estrogens are not really great after spinal cord injury. If you have an IUD implanted, it can sometimes cause autonomic dysreflexia if there is any extrusion or any problem with the uterus. And you might not even know that it's extruded. And of course, preference, patient preference. Again, when we look at, the fertility is really not the issue, but contraception is, and then labor and delivery have its challenges. And pregnancy has a high risk for worsening secondary consequences. So all the things that are already experienced tend to get worse, especially UTIs, and quads have some respiratory issues with the large uterine size. Constipation gets worse, skin breakdown, mobility needs to be monitored by OTs and PTs so that you don't wear out your shoulders and be too fatigued when you finally have a baby. Spasm also increases, transferring is a problem. And when you're in labor, it can present very differently, and I'll talk about that because you must distinguish autonomic dysreflexia from preeclampsia, which could be lethal if you don't. Compared to 30, 40 years ago, where everybody had a C-section, now vaginal birth is the rule. And we have some postpartum issues that are well known, mainly postpartum depression, some motor difficulties on moving, handling baby, fatigue, and some breastfeeding barriers. So if you have a high level lesion, you're going to have impaired milk let down reflex. And we can sometimes stimulate this with galactagogues or antipsychotics or hormones and herbs, but it's really not well studied. We're looking at the non-SCI population for guidance here. But a lot of women that try to breastfeed have difficulty and they feel like failures. And we really want to make sure that that is recognized as something normal to expect, that you just try your best and there's lots of help for you. And the last thing is that we need lots of postpartum adapted equipment. And there's some really ingenious things that are being developed to help. You need a multidisciplinary team pre-pregnancy, pre-planning, for the hospital to make sure everything's available and accessible, and afterwards. So having a multidisciplinary team to follow you through all those different areas is very important. We have a pregnancy and spinal cord injury guide. Again, it's on the same site. You can download this and it can be very helpful because women complained to us that it was hard to find information on the web. It was all to do with people without disability. What about dysreflexia? I think this is quite important. It's quite common, especially if you have high arousal, not even orgasm. Orgasm makes it even worse during sexual activity. And again, this could be a real problem where women don't want to be sexual because of the dysreflexia triggers. And so that would be somebody that we would use prophylactic antihypertensives for. AD is more likely to be triggered in pregnancy because of the increase in UTI. It's a higher DVT risk. There's some uterine pressure on the venous return. We don't know, but it's certainly more common. And sometimes the preterm contractions or labor can be very hard to distinguish after spinal cord injury. It can present very differently, including with AD. And at least more than half of the women that get dysreflexia that have injuries above T6, even if they have no prior AD history, can get very severely dysreflexic during labor. So this is why you need to be monitored. Even an episiotomy in some cases can trigger AD. And when you have dysreflexia, of course, that interferes with the uteroplacental blood flow. So you've got to monitor the fetus very carefully, especially when the dysreflexia is present. Now you have to distinguish AD, which will be symptoms of autonomic dysreflexia with contractions, compared to preeclampsia, which is hypertension during the labor period with protein in the urine. And if you don't distinguish it, that's why it can be very, well, it could be lethal because there have been strokes during labor that are with unprotected AD. So it leads to serious consequences. Often epidurals are done to prevent this, but you need, again, a multidisciplinary neonatal team to help. We also did an international study on breastfeeding, which was the first that was done, and looking at dysreflexia. And if you look at the paras all the way to the tetras, you can see that the incidence of AD with breastfeeding goes way up to 40% in those with high quads. We did publish this, and we also published a consumer guide that you can find on SCI, which is the website that is for professionals and for people with disability. And there's a consumer guide for mothers, which would be very helpful. It has to do with how to hold the baby, how to breastfeed, etc. Another thing you might want to have a look at is our spin magazines and SCI BC. There's one, you could just download these PDFs, one on motherhood, one on pleasure principles around sexual activity and neuroplasticity, which we think is the reason that you can be orgasmic after spinal cord injury. There's also some work on neuromodulation of the spinal cord that can improve some sexual functions in some persons. And a toy box, which is some fun gadgets that are used for people with disability. And lastly, the most recent one is the winter 2025. And in this one, there's a very good article on menopause with some of our experts in BC called Feeling the Heat. And with that, I'm going to transition to Dr. Sims.
Okay, so I will talk a little bit more about menopause and spinal cord injury, and some of the overlapping and concurrent symptoms. So menopause is defined as the permanent cessation of menstruation and is related to the loss of ovarian follicles and low estrogen levels. It's defined as starting 12 months after the final menstrual period. The average age of menopause in Canada is 51 years old. And I do just want to mention there was a relatively recent retrospective study looking at incidence and epidemiology of spinal cord injury in BC. And we do see that the average age of people who are sustaining spinal cord injuries is increasing. So between 2001 and 2021, the average age of spinal cord injury was 51 years old for all genders. And in the earlier 2000s, it was closer to 42, and then more recently closer to 57 and a half years old. So this will be relevant both for people who have had a spinal cord injury and are transitioning through menopause and perimenopause, as well as people who might have a spinal cord injury around the same time as this transition. So, as we know, if someone sustains a spinal cord injury, this is often described as a very significant life transition. And spinal cord injury is the area that I'm more familiar with than menopause, but have been learning more with working with Dr. Elliot and the sexual rehab team. It was interesting to review some of the evidence related to menopause and also being obviously regularly described as a significant life transition. So both of these transitions can affect multiple different systems. And it's important when we're providing holistic care for our patients to think about how these individual and different experiences that people have can either compound each other or affect each other. So there's been fairly limited research previously in the area of menopause and spinal cord injury, of course, as also in many other women's health areas. Here in BC with Dr. Elliot, there was a committee group that was created with clinicians and people who had spinal cord injuries to look at identifying top priorities for future research for women with spinal cord injury and menopause. Through this initiative, they identified the top 10 priorities for people with spinal cord injury, and we'll review some of these today. So we'll pick 4. We'll talk a bit more about vasomotor symptoms and how this might overlap or impact autonomic changes with spinal cord injury, looking at bladder function and how that can be impacted both from menopause and neurogenic bladder, look closer at bone health, and tie back to some of those sexual distress issues. So first, looking at some of those autonomic changes and thermoregulation changes. So in menopause, vasomotor symptoms are experienced by 60 to 80% of women during and after the menopause transition. These are typically in the form of hot flashes or flushes, and they can last for around typically 1 to 5 minutes, as well as night sweats. These are often considered the cardinal symptoms of menopause. When someone experiences hot flashes or flushes, they can experience predominantly sweating and flushing and change the color of the face, head, neck, and chest and upper back. This can happen unpredictably, and the underlying trigger is related to hormonal changes and thermoregulatory dysfunction. We don't understand all of the different mechanisms that are at play in some of these in the underlying pathophysiology, but likely there's also a role of the autonomic nervous system impacting these symptoms as well. Specific to spinal cord injury and people who have an injury at the level of T6 and higher, autonomic dysreflexia can be a common issue and is an exaggerated sympathetic response and increase in blood pressure that is a bit more predictable than something like a hot flash, but is often triggered by bladder or bowel dysfunction, and can also be related to sexual response, skin changes, and other things. But to differentiate from menopause, there typically will be a trigger, and symptoms can be improved by removing the trigger as opposed to kind of being spontaneous and unpredictable. It's also important to consider that outside of autonomic dysreflexia, there can be general thermal dysregulation in spinal cord injury, so even further overlap with some of these menopause symptoms. The primary treatment for menopause-related vasomotor symptoms is systemic hormonal replacement therapy. This is typically both a combination of estrogen and progesterone. The estrogen is almost always transdermal, so whether that be an ointment or with a patch. With my role as a physiatrist, I don't routinely prescribe these medications, but I do think it is important to flag this for their primary care provider if these are symptoms that they're having. In general, also with menopause, we can see that women have a higher risk of having just general hypertension. So it's also helpful to consider doing more regular monitoring of blood pressure so that we can have a better baseline to understand if someone is meeting those thresholds or tipping into autonomic dysreflexia, or if there's just kind of been a gradual change in what their resting blood pressure has been over the years since they've had a spinal cord injury. So talking a bit more about bladder function. So in menopause, genitourinary syndrome of menopause is a term that encompasses a range of symptoms and physical changes that affect the vulva, vagina, and lower urinary tract, and they can impact sexual and urinary function. Unlike hot flashes and vasomotor symptoms that typically improve with time, these genitourinary syndrome of menopause symptoms tend to worsen if they are not treated. There are hormone receptors to estrogen that exist throughout the female genitourinary system, and the depletion in estrogen results in changes such as vaginal epithelial thinning, vaginal dryness, decreased blood flow to the vulva and vagina, and this can present with pain with intercourse as well. We see changes to the vaginal pH that can increase risk of urinary tract infections, and it becomes more common to see changes with urinary incontinence, such as stress urinary incontinence and urge urinary incontinence. In spinal cord injury, we're familiar with managing neurogenic bladder. Relating to the symptoms of menopause, one of the important considerations would be the ongoing use of catheterization. So whether that be an intermittent catheter or an indwelling urethral catheter, which would be a little less common. But with the changes to the skin, we would want to consider increased risk for skin trauma, bleeding, and these kinds of things. They're also at increased risk for urinary tract infections with a neurogenic bladder. And so this, with the additional increase of risk of urinary tract infections from menopause, can be compounding with an effect on morbidity. Some of these genitourinary syndrome changes in terms of friction and pain with intercourse can also be a further trigger for autonomic dysreflexia. So the mainstay of treatment is typically topical vaginal estrogen. And again, I would typically defer to the patient's primary care provider for giving this prescription, but always can be important to flag. Or I've also shared patients with urology who will start this medication for them. Separate from that, there's also vaginal moisturizers that people can use regularly. Important to stay hydrated to reduce any kind of increased concentration of urine. Smoking can be something that increases estrogen metabolism, so canceling on smoking cessation. And per the menopause guidelines, I recommend regular sexual activity, as this can help improve blood flow to the area. And for trying to address some of those symptoms of friction and dyspareunia, can typically recommend water-based lubricants. And just a little bit on bone health. So people who go through menopause have higher risk for osteoporosis. Women typically have peak bone mass around 25 to 30 years old, and then bone loss starts during the perimenopause phase. Typically see the greatest loss of bone mineral density in the first 10 years after the final menstrual period, and at higher risk for fragility fractures. In kind of just general terms, that's typically increased risk for vertebral body fractures, proximal femur fractures, and distal radius fracture. So for someone who also has a spinal cord injury, we also know that there is rapid loss in bone mineral density following spinal cord injury within the first year. and that within 1 year, over half of people with spinal cord injury will have sublesional osteoporosis. With spinal cord injury, we often see atypical sites of fracture, such as at the distal femur, proximal tibia, and ankle. The osteoporosis in spinal cord injury is multifactorial, with the main causal factor being mechanical unloading and change in bone formation, resorption, balance. So when we're thinking about treatment, we're kind of looking at, increased risk factors for osteoporosis, and in general would always recommend that people be on vitamin D. There's some variable resources in terms of dosing of vitamin D, but somewhere between 1,000 to 4,000 units per day. Taking supplemental calcium can be problematic in terms of some side effects like constipation, gas, kidney stones. So often recommend people review the amount of calcium in their diet and see if they can try to increase calcium-rich foods. Smoking cessation can also be helpful for bone health. And resistance training as tolerated, which likely would need to be individualized based on the person and their level of injury. So we know that bisphosphonate medications in postmenopausal women can be helpful in increasing bone mineral density. But when we look at women or people specifically with spinal cord injury, previous studies have not showed that specific to spinal cord injury and sublesional osteoporosis that we can increase bone mineral density, but there is some evidence that it can be helpful in maintaining. We don't routinely prescribe bisphosphonates or anti-osteoporotic treatment following spinal cord injury, but when we're looking at all of these different risk factors, it can help inform doing tests such as the DEXA to look at bone mineral density and counseling on anti-osteoporotic management. Okay. And so looping back to the framework with Dr. Elliot, and just thinking about how some of these changes related to menopause can impact sexual functioning. So we reviewed how specific with some of the genitourinary symptoms of menopause, it's not uncommon to experience reduced libido. We consider some of the sexual functioning abilities with changes in terms of vaginal dryness, changes to the tissues within the vagina, and increased pain with intercourse. The transition into menopause associated with fertility loss and how that overlaps with some of the fertility changes their experience with spinal cord injury. And then considering things like autonomic dysreflexia and autonomic symptoms and how they can be exacerbated by even things like the vasomotor changes. So those hot flashes actually can also make autonomic dysreflexia worse. So there's a lot of overlap and things to consider in terms of the factors with the condition. With any change in pain, we can also see increase in spasticity, which can also impact sexual function. We reviewed some of the bladder changes and how this can impact. We also do see some changes with bowel function with often increased constipation and gastrointestinal upset with menopause as well, but we didn't dig too much into that specific symptom. And it can be very common for women to feel unseen or have a change in their sexual self-view and self-esteem. It's also very common to have metabolic related changes with menopause, and this can impact that sexual self-view and self-esteem as well. So this is a slightly blurry, but it does work QR code for the top priorities study that was done by Dr. Elliot and colleagues here at UBC. So this will have more, this is just a direct link to that SCI article with more information. And you're welcome to contact us if any questions.
Thanks.
Mm-hmm. All right, ladies, I really appreciate hearing all of that. We do have some questions. Let me just start my timer here. So we have 10 minutes for questions. We have one here, question for Stacy. how have you treated persistent sexual arousal disorder with someone with Coda Aquinas syndrome?
Well, it's kind of two different things, right? Like the spinal cord injury can certainly contribute to that. But when we look at low desire disorders, we kind of look at the biological component as well as the motivational component. So the biological component would be to make sure that their hormones are the best, that they're not depressed. Maybe they should be on an antidepressant if that's the case. And is there anything with their thyroid going on, etc. So the medical part of it, I think, is really important that we can rule out and treat. But the motivational part, that becomes very different. Is it painful? Is there something we can do in terms of reducing the secondary consequences that make you turned off from being sexual? But often it's a partnership issue or a life issue, right? And so that's where this multidisciplinary team comes in, you know, with rec therapists and psychologists and things. How can we improve that quality of life? Because once you're healthier and once you're happier, your sex drive tends to go up. The persistent arousal disorder that they use flubanserin in or testosterone in, we don't have any information on that with the spinal cord injured population at all. I would be very careful about using testosterone in women, especially premenopausally, because that will make their own ovaries and their own hypothalamic gonadal tract decrease, right? Doesn't make any sense. But after, sometimes testosterone has been used, and we don't have any information after SCI around that. So testosterone tends to be used a lot more in the States. We don't use it very often here. Addy, which is flubanserin, has been used, but it really has not shown what it's supposed to show. There's just a few more incidents per month or something like that. So really it comes down to this biopsychosocial approach, and that's why you often have to refer, because it's quite complicated. But I think as healthcare professionals, we just take whatever our specialty is, whether it's more medical or psych or whatever, rec therapy, to try to make the quality of life the best that they can, and that will be helpful. It's a long answer, but it's complicated.
You're right. It's complicated. I have another question here for you guys. What women's health issues are most commonly missed or under-recognized in people with SCI, especially around perimenopause and postpartum?
Well, I think the most common one is that the whole perimenopause and menopause is disregarded. It's disregarded in the able-bodied population, let alone SCI. And I think a lot of the practitioners are quite afraid to touch it. They think, well, we'll just send it to the SCI docs or the physiatrists. You know, they understand it, we don't. And I think women have to advocate for themselves. So it's interesting. There's quite a few more publications coming out. That's why we did this study, is, you know, what should be focused on. And so I think if patients can advocate and say, look, first of all, testing premenopausal is not going to be very helpful in terms of blood work. And I'm not a menopause expert, but basically we try to alleviate the symptoms, as Dr. Sims was saying. And if you can use some, especially around the vasomotor, if you can control some of that, that is really helpful. But the big problem is it's dismissed. It's dismissed by everybody, and nobody's quite sure who's the person to do it. So fortunately, we have a gynecologist here who's working in something called complex menopause, and SCI falls under that. So you're going to see more and more information come out. There is a few papers, if you go to PubMed, on menopause now and how to treat it. So I think it'll be much better in 5 years. But so that's the one main one. What was the other one? That's most common, I think, around pregnancy, is not getting their ducks in a row. Not getting pre-pregnancy counseling on what to expect and what to do. People just get pregnant, and then the healthcare providers, they might have one pregnant person in their whole practice. So you need to get the perinatal teams involved initially, prior to considering getting pregnant if possible, and to follow that through. Simple things like going to emerge as a quad and having a pressure of 120 on 80, and everybody says, oh, well, you're fine. Let's just monitor. You're already dysreflexic. So, but they don't know that. So it's really important to go to healthcare providers or OBGYNs that have the experience in that. Any other thoughts?
Yeah, I mean, there's more resources like Dr. Elliot was saying. I think part of the lack of treatment sometimes was just older studies that created a bit of fear around hormone replacement therapy. So even just having these conversations with people and then encouraging them to bring it up and with their primary care provider, I think is helpful and kind of a good advocacy role.
Yeah, I think you have to avoid oral estrogens, right? But otherwise, not to be so afraid to use estrogen therapies, transdermal or patch, or especially vaginal, is just not an issue, and that should be treated more assertively because the secondary effects of the bladder, the friction, the skin thinning can be prevented, and it's really important to acknowledge that. We're trying to get urologists to look at it as well as gynaes, as well as primary care. So there'll be more information on it. That article in Spin is a little bit helpful too, if you want to look at that.
Definitely. I have that magazine sitting right next to me, so I'll be reading that. Um, we just have about 3.5 minutes left for a question. I'm trying to choose between these two. So how should bowel, bladder, and spasticity management be adjusted during pregnancy and in the immediate postpartum period?
Well, I think I don't know what you mean by adjusted. If there's a problem, I mean, you have to do whatever you normally do to help. The issue is that there needs to be more frequent OT and PT assessments so that it's not missed. That's my understanding. I think a lot of people feel, I'm pretty independent. I can transfer, and suddenly they fall out of their chair. So we want to avoid all that. So I think that perinatal care is really important, and to go to rehab and make sure you're seeing everybody and not just, your OBGYN to avoid that.
Fantastic. And then lastly, if you could give one key message to every clinician caring for women with spinal cord injuries about pregnancy and menopause, what would it be?
You can do it. You can be a parent, and that shouldn't be discouraged. I think that's wrong. I think it should be encouraged. But to gather your resources and gather the team and set it up. And that is a lot of patient advocacy, I have to say, especially in smaller towns. But you have to do that, right? And you avoid a lot of the consequences. So we're trying also to get some primary care webinars and videos and pamphlets and stuff like that, so that, I don't blame a primary care physician for being terrified of, somebody coming along and being pregnant, like, oh, what do I do? But if there's more information and they've got the resources, then that's going to be very helpful. And they really are coming out now. It's way better than it was 10 years ago.
Okay, Julie just sent in so there are apparently some testosterone questions in the Q&A if you feel like typing an answer. Sorry, I wasn't aware of those ones. Apologies for that.
The other thing is maybe they could be sent to us and we can email some answers back. Might be a better way to do it if you like.
You've got it. All right.
And I don't have the answers to everything, by the way.
No, I really appreciate you sharing, and especially just sharing all of the resources and information with us. I mean, we need everything we can get here, right?
Well, same in BC and same in Canada. So yeah, we're working on it. But the SCI sexual health site, I think, is very, very helpful. And so Skyer, we're updating the sexuality one on Skyer. So that should be out in a few months too.
Fantastic. Thank you so much, ladies. Really appreciate you coming, joining us today, sharing. We are going to take a 5-minute bio break, and Julie will set us up with our next speaker. But I hope you guys have a lovely afternoon, and thanks again.
Thank you.
Thank you.